Good evening, everyone. We're going to go ahead and get started. We want to be respectful of your time. We want to be respectful of our speakers' time. I want to welcome you. My name is Heidi Lang, and I serve as the Pre-Health Professions Advisor here at Saginaw Valley State University. We extend a warm welcome to everybody that is in the audience with us on campus, as well as those of you that are attending virtually from across the state of Michigan. It's important to note that today's lecture is made possible through a partnership between SVSU and Michigan State University College of Human Medicine. We're delighted to welcome Dr. Sean Valles for tonight's public lecture, which is titled Housing is a Basic Health Need, Lessons from the Pandemic. Little information for you about our speaker. Dr. Valles is director and professor in the Michigan State University Center for Bioethics and Social Justice. He is a philosopher of health, specializing in the ethical and evidentiary complexities of how social contexts, everything from one's local food options to the presence or absence of exposure to violent policing practices, combine to create patterns of inequitable health disparities. His work includes studying the challenges of responsibly using race and ethnicity concepts in monitoring health disparities, scrutinizing the rhetoric of the COVID-19 pandemic as an unprecedented problem that could not be prepared for, and examining how biomedicine meshes with public health and population health. He is the author of the 2018 book, Philosophy of Population Health, Philosophy for a New Public Health Era. He is also co-editor of the Oxford University Press book series, Bioethics for Social Justice. Please join me in extending a very warm welcome to Dr. Valles.
Hello, everybody. Thank you for being here, both in person and online. I have no idea how many there are online. I'm not really good at judging numbers in person either. So thanks for being here on this evening. I'm sure you had other ways of spending this evening, and I appreciate that you made this choice instead. So I want to talk a little bit about housing and health. That there is a connection seems relatively obvious. I assume you prefer to have a roof over your head at night as opposed to not having one. But one thing that has really come up during the COVID pandemic is it made us start examining the relationship between housing and health in some slightly different ways. It created some new challenges, or more accurately, it made some old challenges worse, and is now forcing us to have a reckoning. And so I go around and I give versions of this talk because I want us to at least to have a better conversation and a richer conversation about what kind of world do we want to build and how does housing fit into it as we sort of recover from this very traumatic event of the pandemic. We're not fully there yet. We're working on it. Just had COVID in my house recently, so it's not over. I don't want to imply it's over, but as we're sort of coming out of it gradually. I do love working in the College of Human Medicine. We are spread throughout the state, and it is a privilege to be here as a part of our sort of outreach efforts to be connected to the rest of the state, and it makes me very happy, and thanks for letting me be here. Just a quick little plug for my college. Contrast to conflicts of interest, I have a house, and so there's that, but aside from that, I can't think of any other conflicts of interest. So I made the mention of the pandemic. And I think really, while everyone I think is kind of sick of talking about the pandemic, so I'm not going to talk like all COVID stuff today. That's a whole other talk that I'm just not going to give. I do want to give a little bit of time to think about this idea that a lot broke, and no matter what, we have to do some rebuilding. And so the economic system is currently rebuilding. Trying to get inflation under control is still still a work in progress. Trying to get enough staff to work at various kinds of restaurants and hospitals and all sorts of other places is still a work in progress. So we are rebuilding, whether we want to talk about it or not. And so I appreciate that we're having conversations around what kind of rebuilding do we want to do, and so what should the future of travel be? What should the future of work be? Or how much are we going to have work from home? All these kinds of things, they have really big implications for everything, especially the stuff like to what extent do we want to do remote work versus in-person work? Huge. And so I'd like to include in that talk, what do we want to do when it comes to housing? So I want to give a little bit of context here about what exactly I'm talking about. So the area that I sort of work in a bunch of different areas. As you guys sort of heard my little introduction, I have a background in history and philosophy of science and in bioethics and in genetics and a bunch of other different things. But the thing that really interests me is I sort of go around and my sort of shtick is I try to undermine what has recently been called the fallacy of health inequity fatalism. And what that means is that it is a fallacy. It is just logically false. It is an untrue thing that people tend to believe in the world, that when we sort of see these patterns of injustice where some people get sick and some people either get better and other people will just die from it. And it just doesn't have to be that way. The fallacy is that like, oh, that's the way the world works. You know, people get sick, people die. That's just the way of the world. We can't cure everyone. True. You know, I work at a medical school. Like I understand, like not everyone is going to get better. Like that happens. Some people are born with some sort of condition that makes it so their heart can't function. Some people are born with genetic diseases that are 100% fatal. It just happens. It is a thing that will exist in the world. But that isn't the reason why that, for instance, right here in this neighborhood, the life expectancy is 82. You go a few miles south, 66. Why is that? There isn't a separate genetic population that's living a few miles south towards the northern end of Saginaw. I was just looking at some data a second ago. I was just sort of curious. It doesn't explain why the town where I grew up, if I walked 2 blocks west, then the life expectancy would be about the same as where I was. But if I walked 2 blocks east, it would go down by 10.6 years. And so, like, what's up with that? And the main thing is, well, first of all, it's a lot of things are going on with that. But the important part is it doesn't have to be that way. There wasn't something about that arbitrary line that existed between this town and this town where something was different. It was people had different kinds of occupations, different kind of housing structures. The housing was in poorer quality in that part. You've all been in a neighborhood and then you crossed over the tracks and then you're in a different neighborhood. That shows up in health. And again, it doesn't have to be that way. Okay, just to give some brief numbers about what kind of scope and scale we're talking about. I'm going to run through some figures here. Some of the more detailed numbers are coming out of California, where they actually have the biggest concentration of unhoused people at the moment, for a variety of different reasons. It's very expensive to live there. They have big population fluxes. A lot of people buying up housing, so they're sort of like ground zero of housing crises in the United States right now. It'll probably change at some point, but that's where it is now. So there are about 104,000 Californians who are in state prison. The Department of Corrections spent about $14 billion, just for comparison about what kind of scope and scale of how much money we're talking about here. There are about 174,000 Californians who are experiencing homelessness. And the most recent calculation about how much it would cost to get rid of homelessness entirely in the state, including building new housing so that everybody could have a roof over their heads, is it would cost about $8 billion a year, so about 3% of the state's budget. And so when people look at sort of this problem of like, oh my God, there are so many people experiencing homelessness, what are we going to do? This seems like an impossible problem. Not really. It just really isn't. And this is the place where it's kind of the worst in terms of like the severity of it. And there will always be fluctuations. Right now, there's a massive crisis with people basically people either as refugees or as forced migrants trying to move across the U.S. border in order to seek shelter because they have no other safe place to live. And so you'll have fluctuations where like, what are we going to do with this many people crossing over at this particular moment? Or in another year, it might be a different population. There will always be those challenges, but again, it doesn't have to be this severe. And so it is not impossible, and we're spending more money on other things that we could be spending on housing. And so we have to make decisions as a society about how do we want to spend our money, because it is our collective money. Okay, I'll try to go through this quickly. It's generally a good idea to refer to people with what's called person-first language. And so, so when we say, so homeless is an adjective, it is not a noun. And so we can talk about a person experiencing homelessness. This is just a matter of basic common courtesy and human decency to try to be respectful towards people. We can talk about unhoused person. It can be, some of this is very contentious. People have different ideas. Maybe you have different ideas about how you like to be referred to. Someone else will have other ideas. These are not universals, but try to be respectful in the way you refer to people. And so just be thoughtful about it. There are some technical terms that are involved. And so unhoused or homeless generally means that you don't have stable shelter in a private space that is designated for human use. And so if someone who is camped out underneath a bridge, that is not a home. Someone who is squatting inside a warehouse because it's been abandoned, that also is not a home. And so there can be sort of fine gradations. Some people are couch surfing, and so they might have a roof over their head, but there's no stability to it. And so their host at any moment says, like, I don't want you on my couch anymore. They don't have anywhere to go after that. And so it's also important to think about these things, though, because when we have an idea about what it means to be homeless, we often immediately picture somebody who is living completely unsheltered, and we're not necessarily thinking about somebody who might be one of your friends. Like, well, they don't really have an address right now. They're sort of between apartments. Like, well, that is experiencing homelessness. Just like it frustrates me when we talk about food insecurity as a country. We sort of imagine like a starving child. We don't talk about the fact that somewhere around like a quarter to a third of college students are experiencing food insecurity. And so we do things like, so we'll feel sorry for the child who's experiencing like hunger in the sort of way we imagine it from like watching commercials. But we won't imagine a college student like, oh, they're just eating ramen every night. Ha ha ha, that's funny. That's like the college experience. Like, no, that's food insecurity if you aren't able to afford to have a healthy diet. So I want to sort of challenge some of your thoughts about like what your intuitions are about what it means to be experiencing homelessness and who the problems or who is affected by the problems. Okay, so when it comes to housing insecurity, it's important to keep in mind that when we have a pandemic, and that we've had many pandemics over the years, the most recent one, it serves as a stress test. And so all the things that could break in society, it sort of shakes them up. And the ones that were fragile are going to shatter, and the ones that were well designed are going to be okay. Not a lot of ours really went that well. And so you have hospitals filling up with sick people. It's very hard to do everything. Everything is challenging. And so what happens? Well, we should look to see what happened to the housing system after we sort of shook it up. And we already knew before then that it was too expensive to live. It was that housing costs had been rising. Wages had been staying relatively flat. And so if you've ever rented your own home, or if you bought a home, you can sort of see that like it's getting really expensive to try to live somewhere. So in the estimate, they do this every year, and it takes a while to get the data out. In January 2022, the way we typically collect this data in the United States is they do what's called a point in time analysis. People will often sort of float in and out of experiencing homelessness depending on the day, sort of like, like I have a house, like, oh, but I couldn't pay my rent, so people kind of come and go. And so what they do is they just pick a date and they say, on this day, how many people are experiencing homelessness? That's sort of single point in time. And so it's about 0.17% of the United States, 500,000 people. That has gone up a little bit since then by most estimates. About 60% were in temporary shelters of some kind, and about 40% were unsheltered. So roof, no roof. A lot of people. I'm going to go through some of these statistics quickly, but I really think it's important to recognize. We don't have a lot of data about the health of people who are unhoused, because if you don't have an address, it's very hard to collect data about people who do not have an address for sort of the intuitive reasons that we sort of don't. These are that if you are experiencing homelessness, you're kind of like outside of society in a lot of ways. You are not showing up on statistics. But average age at death. So basically, if you go to the morgue and you find people who were experiencing homelessness, and you sort of see like who's showing up there, it's young people. And that's really, really upsetting. And so people are showing up in their early 50s on average in the US. It's even a little bit worse in the UK. And it's so it's not necessarily that the life expectancy is in the 50s or 40s, but it sort of gives you a sense about like when people die, it is not old generally. If you look during the COVID-19 pandemic, there was a spike in mortality in people living in shelters, which is kind of intuitive. You have overcrowded spaces, people coming and going. It's very hard to have pandemic safety there. There There were also spikes sort of across in various other places where they tried to find measurements, sort of seeing like what happened during COVID-19 with people experiencing homelessness, and it was basically a lot of bad signs. I don't think it's gonna be years and years before we even have better estimates about how bad it was exactly, but not looking good. So you have disruptions from government or NGO services. Some of these aren't just from COVID-19 itself. It's what happens if the hospital you want to go to for basic care, because you want to go to the ER, is now filled up with COVID patients, or you want to get an appointment with a social worker, but there aren't any who are available, that kind of thing. And so what you end up with is, if you have a housing insecurity, then you get into this really vicious cycle with illness. And so you don't have sufficient housing, you don't have enough money to pay for it. You might get stressed out. You might not have the best eating habits, either because you can't afford it or because you're depressed about your situation. For instance, there are a million different reasons that can cause illness. And if you're sick, it is very hard to continue to have employment and to continue getting income. And if you can't afford to if you don't have income, then it is very hard to pay for that housing. And so you get into this cycle of sickness, poverty, sickness, poverty, sickness, poverty, and housing insecurity is part of that cycle. And so what I want to try to orient you towards is what one sort of like response to the problem of the fallacy of health inequity fatalism is to do what's called upstream thinking. And that's a response to what McMichael, relatively famously, called being prisoners of the proximate. He says it's very easy, especially for people who work inside medicine, to think only about like, okay, like what happened to this patient in front of me? This person was exposed to the cold for too long. Okay, so I'm going to deal with all the problems that are brought about by them being outside for longer during the winter than they should have been. Makes sense. And so you're looking at, okay, so how long were they there? Did they slip and fall? Like what else is going on? And you want to find all the different things that are affecting this person. But it's really easy to sort of overlook, why did they end up in that situation in the first place? And so you can always ask, why did it end up that way? Why did that happen? Why was there a person who was outside in the winter? Was it because they wanted to be there, or is it because they didn't have a roof over their head? And so then you can start taking yourself out of like, how do I deal with this one person situation right here, and into the mode of thinking, why are there so many people who are experiencing these same sort of problems again and again? Why are there so many people with substance use disorders, for instance? Is there something going on? So it's not just like individual behaviors or like a bunch of people wanted to do this. Like what we should look at patterns, and we should look at the reasons why things are happening in our world. And so it can be lots of different things. It can be climate change. It can be economic inequities. It could be inflation. It could be housing costs, whatever. So you probably, I can move on from this. It's important to keep in mind that this isn't just a matter of only the people who are experiencing the worst of poverty. So if you look over here, this is one of my favorite graphs. It's very depressing, but it's favorite. I'm saying the loose sense of like, this is interesting to me. This is income percentile. And so down here, up here is the richest 1%. Down here is the poorest 1%. This is life expectancy at the age of 40. You can do these calculations for basically an adult. You can do them for someone at birth. Kind of doesn't make that much of a difference, just different numbers. And the thing that's fascinating is you have this kind of relatively smooth gradation going up like this. It's different for women and for men. That's a much longer story. But the fascinating thing is that there was this sort of like intuitive idea that like, if you are experiencing severe poverty, that like it would be bad for health, like you can't afford to eat, for instance, and that it would be kind of helpful if you are fantastically wealthy and you get to have whatever you want whenever you want it. Like I can hire my own personal team of doctors every time I have a cold. Sure, go for it. I can have a personal chef make me all the healthiest meals that I want. But what people don't talk about is that like, why are people who are in the 62nd percentile doing better than people in the 61st percentile? And why are the people in the 61st percentile doing better than people in the 60th percentile? That every single dollar matters. And that's fascinating. And it's very also fascinating if you look between different countries. Most other countries where they collect this kind of data, everyone's got a slope. Ours is really steep. And so ours goes woo, down real fast. And so again, if you get sick, it's very easy to sort of slide down that economic slide, and it's very hard to get back up. Okay. housing is really interesting, especially in the United States, because in the United States, housing and wealth go together. Wealth gives you the ability to get housing, but also a lot of our wealth is in housing. And so, so the median wealth of homeowners is about 40 times higher than it is for renters, which is wild. But also a lot of that is just the difference between the wealth is that you own a home. It is a very valuable object. That sort of pattern of like how much wealth is sort of in the form of cash versus in or in investments versus in like the physical property is different in different places. In the United States, a lot of our wealth is just in homes. And so that's really important. So if we don't deal with housing issues, we're not going to deal with economic inequity issues, because housing and economic equity are very, very closely linked together. And this also plays out in ways that you might expect in terms of racial and ethnic disparities. So non-Hispanic white families, so median wealth is about 8 times higher than the Black families and about 5 times higher than Hispanic families on average. Okay. So during the pandemic, there was an effort to try to deal with the problem that if we are in the middle of a pandemic and we have people being evicted from their houses because they are, for example, a restaurant worker, and the restaurants are partially or totally closed for a period of time. Okay, there goes your paycheck. Most people live paycheck to paycheck. Most landlords want to be paid every month, not just most of the months. And if you don't pay your rent, they say you are evicted. Well, that would be a big problem if everyone's getting evicted during the pandemic. That could cause like the collapse of society. What are we going to do? Let's have a temporary policy where you say, okay, it's the middle of a pandemic. Let's not be ridiculous here. You can't just kick someone out in the middle of a pandemic. You can't just evict them. That'd be ridiculous. What are they going to do? This would be a bad idea. This would hurt everybody. And so there was a temporary policy where the CDC put out a recommendation, and this was eventually followed up by the federal government. They say, temporary rule, you can't just evict someone in the middle of the pandemic. So they put out what's called a pandemic moratorium on evictions. There were similar policies in other countries. The UK did one that was relatively similar with some important differences. And immediately landlords freaked out for the obvious reasons, because they wanted to get their paycheck every month. And so there was this immediate tension between the people who were controlling the housing, who owned the housing, and the renters, which is a very large proportion of the country, where we wanted to prevent people from being evicted. We also want to make sure that landlords weren't being unduly harmed. And so the landlords, they fought back and they said, you can't do this. This is ridiculous. You're putting all of this on our backs when it should be someone else's responsibility. Eventually, the Supreme Court decided that they would basically not allow this to move forward, and so eventually it was shut down. Although by the time that happened, it had already been in place for a while. Interestingly, there had actually been a precedent for this. There was a policy during the Great Depression where a different Supreme Court decided that Wisconsin would be allowed to basically give mortgage payment extensions during the Great Depression, because they didn't want to have everyone defaulting on their homes all at the same time during the Great Depression. That would be like a bad thing for society. And so Wisconsin sort of gave everyone like an extension on their mortgages. And they decided at the time that was okay. Different Supreme Court, different ideology. Lots happened since then. But the thing that's interesting, even though this policy was shut down, CDC tried it. I think it opened up the door to a really interesting conversation. Because then, to me, I'm sort of looking at this and saying, like, the CDC made a case that, like, it would be ridiculous to just be kicking people out onto the street in the middle of the pandemic. What are they going to do? This is ridiculous. And I'm sort of looking at this as like, if you know anything about the data on homelessness and health, and like some of the data I just showed you, well, it's like, well, is there ever a time when it's a good idea to kick someone out onto the street? Like, it's always like unreasonably dangerous to someone to evict them. Like, what if we never did that? What could we do instead? Instead of allowing people to be evicted from their homes on a regular basis and kicked out and maybe pushed to another place. And so I think this is sort of opening up an interesting conversation about, or I hope we have the conversation now, about what if we thought about this differently? What if we didn't just have people being kicked out all the time? What could we do to make that a thing that's possible? Because it does seem economically, for instance, in California, that that's a thing they could do. they could spend less money on prisons, for instance. They could spend more money on housing. That's one contrast I make. Oh, you could use all sorts of different money on this. Or you could raise taxes, or you could lower taxes and increase them somewhere else. Like there are lots of different ways we can sort of use our collective money. People complain about how much we spend on the military. Other people complain how much we spend on various parts of agriculture. There are lots of different ways we can sort of move money around as a society about like, what do we want to invest in? These are priorities we can set. Oh, a question? Oh, sorry, that's the mic won't pick you up. So if you can speak into the.
With the with eviction, you said if we spend less money on eviction and more money on housing, like in states.
Oh, sorry. We can spend more money on housing and trying to prevent people from being evicted, and less money on, I don't know, like what else is there? No, lots of other stuff.
But wouldn't those people still be evicted because the housing will be government housing? So people are. Oh, sorry.
Oh yeah. Well, yeah.
People are evicted because a lot of times they just aren't paying the rent or they can't afford the rent, and unfortunately, tenants landlords just can't. Landlords have bills to pay too, and that's the reason why people are getting evicted in the first place. So if we rely on government housing, wouldn't eviction still be a thing basically? Because
not necessarily. So depending on the country, and lots of countries have experimented on very different ways with this. One model is if you can't pay your rent, then the government writes your landlord the check instead. And so it's still the same. It's the same landlord, same renter. But if you aren't able to pay for it, then the government steps in and basically has a safety net where we don't have one. And so then everybody gets paid. Oh, let's wait till the end to have a follow up on that, because otherwise I do enjoy being interrupted, but otherwise if it goes back and forth, I've never actually finished in the time before the people online decide to quit, which may have already started. But that's on me, that's not on you. Okay. So part of what's going on here, and this is what's interesting to me as someone who works in ethics, is there is like a tension underneath this. So it's not just that landlords want to get paid. There's also like some very important contrasting ideas about how do we think about the role of health in society that's sort of like under the surface here. And there is like a legitimate, interesting debate to be had. And it already actually been happening for years inside my field, inside bioethics. And so, for instance, in bioethics, especially in public health ethics, which are somewhat distinct but related fields, you have people like the scholar Mark Rothstein, who says that the resolution of underlying socioeconomic and political problems is beyond the domain of public health. And so it is not the job of people in public health, like the CDC, to basically resolve problems with our broken housing system. And so our housing system wasn't able to deal with the fact that we had a big influx of people not being able to pay their rent. Like that's not CDC's job. They're stepping outside their lane. And by contrast, you have people like another scholar, Daniel Goldberg, who says, like they were having a big debate about this inside a journal. Is like, okay, yes, I agree that Rothstein, I agree with him that if we have this very broad model about we need to worry about all causes of health, and so housing and climate change and all this other stuff that's out there in the world, they all sort of impact health. Like that's kind of scary, but then I see no policy alternative, because I maintain, I'm quoting him, that social conditions are primary, if not exclusive, causal factors in public health. Expressly adopting a policy approach that is designed to avoid addressing such social conditions is untenable. And so we're kind of stuck between a rock and a hard place, that we don't want the CDC to be the nation's housing regulator, as that headline said in that previous slide. Like true, but then if the CDC doesn't take any responsibility for housing, then we're not going to be dealing with one of the main drivers of differences between people's ability to live and die. And so we're stuck. And so we don't want to have public health be everything, but if it doesn't deal with everything, then it can do nothing. Because again, every single little bit more money you have, more access to resources, those make real differences in whether you live or die another year, among many other things. And so it's kind of scary to think about this relationship, that we have to either decide to allow public health and so these public health repercussions to be part of all these discussions, or it can be part of none of them and then it can't really do anything. So I come at this from a particular angle. It's called the population health science angle. And what population health science is a field that's sort of an interdisciplinary field that emerged in the 1990s. And it was asking this question inside this volume that sort of started out. It started out at the Canadian Institute for Advanced Research. And they asked, why are some people, and read that as populations, healthy and others are not? Why are there healthy and sick populations? How would you end up with a zip code where people are healthier than other ones? Why could I walk? Why would it change people's life expectancy by almost 11 years if I walk 2 blocks east? What's going on between those different populations? And so what eventually emerged was as it was defined by Keyes and Galea, is it's a research program that confronts the structural forces that place individuals at risk, that creates distributions of health and disease unequally across socially defined groups, think zip codes, and focuses on embedding biological pathways within social interactions that develop across the life course and across generations. And so we can look at things in terms of what kinds of things was this person exposed to? Were they exposed to subpar housing during their infancy? They were exposed to lead paint and indoor air pollution. That led to cardiovascular problems later in life. That made it harder for them to achieve their educational and occupational goals, which made it harder for them to be able to afford medical care and to afford the sort of dietary patterns that they might find preferable. That made it harder for them to have children who were also able to grow up with health. And then it repeats again and again, generation after generation. That's sort of just like a very brief overview about the way this kind of thing can go. So I wrote a book about this, as was mentioned during the introduction. It's also available in Chinese, although I had a great translator, but I don't actually know what it says. I assume it's the same thing on both sides. So one thing I try to get people to talk about is it's very easy, especially during pandemics, as we sort of think about health issues. It's very easy to turn health issues into healthcare issues, but there is a difference. I feel kind of weird saying this as someone who works at a medical school, because like we should always be talking about doctors all the time. And like my main sort of shtick is like, it's actually not the stuff that happens inside hospitals that actually makes people sick or healthy most of the time. Like, sorry. It's like the stuff that people do like the other 364 days of the year before they go to their checkup, where it's like, how am I doing? And it's like, well, there's other 364 days you did C-. Like, here's what we can do to try to get that up to a C+. But like, really, it's like the other stuff that like does it. And so, well, I say the difference between a healthcare system, which is like, hospitals and clinics and that sort of thing, pharmaceuticals. And then there's the health system, which is all the different stuff that impacts our health. It's our housing, it's food networks, it's food security, it's whether or not when you go to Meijer, you can afford to pay for it. It's whether or not if you lose your job temporarily, you're able to find future employment. It's whether or not you have to, or whether you're able to walk to work, whether you can bike, or whether you have to have your own private car. Is there a bus you can take? How much does it cost? How often does it come? Do you feel like you can go to the park and exercise, or you're worried that someone's going to hurt you if you go there? All this kind of stuff makes a difference in people's lives. And so one thing that emerged out of this field, and this is something that I push as one of my main sort of interpretation of the field, is what this means is it's actually a big challenge for us, because we have to think very humbly about what any of us can do in this kind of system. Basically, if all of these things are at play, then we don't get to have doctors saying like, here are the things we need to do that's going to solve all of our problems. Like, doctors don't know that. I know, because I've seen their curriculum. I teach them a lot of it. And so like doctors can't fix all this stuff because they only have a particular angle on it. Nor can nurses, nor can people with PhDs in epidemiology, nor can people who work in exercise science, or people who study sociology of health and why people do the behaviors that they do, or any of the other fields that actually matter to health. Or there are the people who work in urban design who can say, like, if you want to have a healthy city, I'll tell you what that looks like. And it's not what you think it is. And people are like, oh, interesting. If we don't have conversations between all these people, we're never going to get anywhere. And so what it basically means is that if we're not able to humbly recognize that other people and other parts of our society need to be all on the same page with trying to create a healthier world, it's never going to work. If we don't talk to landlords and talk to housing authorities about how to create a healthier world, we're not going to make a whole lot of progress, because if that's a huge proportion of people's income, then what are we going to do? We're not going to make that big of a difference. We need to deal with some of these problems that are fundamentally, they're what some people call, again, upstream. We see all the problems downstream. We see people showing up inside the ER. And so doctors will say, here's what you do with the people in the ER. Great. Why are they in the ER so often? That is an upstream problem. We need to look at what's happening farther up the stream. And so if we don't work together, it's never going to happen. And so we need to have a lot of people involved in these conversations. And that's why I want to go around just saying, like, let's talk about housing and health. There's some intuitive connection between them. But if we don't deal with this, then the next time there's a pandemic, for instance, and I promise there's going to be another one, it's only been within a period of just over 20 years, there were three different coronaviruses that all emerged as potential pandemics. There was SARS, then there was MERS, and then there was COVID. All three of them are related to each other, and the last one really stuck. And so what are we going to do the next time there's another one? The next time there's another flu pandemic or a whatever pandemic, it's going to test us again. And I can't see a single thing that we've done since the pandemic was at its worst that is going to mean that we're going to have any better situation. So what do we do the next time people can't go to work? Are they going to pay their rents on time? If they're not, we're going to have another moratorium. Then the landlords are pissed off because they're not getting their money. And then now you lift the moratorium and then say, okay, great, you owe me 13 months of rent. Okay. Most people are living paycheck to paycheck. No one can pay 13 months of rent. And so now what do we do? It's like, we're going to evict people again. Well, that was the problem in the first place. And so again, like, if we don't deal with this, we're not going to solve our underlying problems. We need to actually deal with some of this stuff. And so there are alternatives out there. There are different ways of thinking about it. I want to sort of briefly go over some of the ways people are talking about it and thinking about it differently. One is that there is a sort of a turning tide in sort of public conversation. It's only sort of bubbling up from the surface now. Part of it is based around the idea that housing is a human right as opposed to a privilege. And so yes, you pay for housing, but you also pay for water. And generally people in Michigan sort of understand that, like, if you don't have access to clean water, that's like a problem. Like, we've all read the news sometime in the last 20 years, right? Okay, cool. And so basic sanitation is a right. The right to a fair trial, these sorts of very, very fundamental things. Like, well, what about housing too? We should think about that one as a human right. And so if it is a human right, then how do we think about that differently than the way we talk about it now, where it's like, oh, like, that's just it's a privilege that you buy as opposed to a thing that is owed to you. And if you can't get there, we sort of owe everyone a way of trying to figure out, okay, like, you can't do housing in the traditional way, so what can we do for you? Just like there are people who can't pay their water bill. Just like in many states, if you can't pay your heating bill during the winter, you don't just shut off someone's heat. That would be ridiculous. That's practically murder. And so, like, we need to think about housing in this kind of way. I'm saying we need to think about, like, what happens to someone if we actually evict them. So if you are familiar with the system, trying to actually get the main sort of way we provide housing support in the United States is very, very, very obnoxiously complicated and hard to get into. And so a Section 8 housing process, you have to be a U.S. citizen or permanent resident to even be eligible for it in the first place. You have to earn less than 80% of the median income, so less than the average income of the region. But really, if you want priority, and since there's a huge shortage, then you kind of have to have priority. You need to make less than 30% of the income for the region. You can't have any history of recent evictions for drug use, which is a problem because there are a lot of people who have substance use disorders, and that's like a medical condition. And, like, what are you going to do? You can't have a criminal record that's been deemed relevant, so there's a lot of subjectivity to it. And also, people who have been to prison also need roofs, just like it's like a thing. You have to meet credit check standards, which is very, very hard because, like, if you don't have any money, like, how's your credit doing? And you still have to pay 30% of your gross income on the housing, even if your income is extremely small. And so it's better than nothing, but it is not great. By contrast, you can look at what other countries are doing. For instance, Finland. Eligibility is, you don't have housing, you are eligible. Because what are you gonna do? Not have a roof outside in Finland? It is cold there. But it's also cold in Michigan. And so these are different ideologies. And so Finland doesn't have zero homelessness, but what they do is they have a system where they're committed to everyone's got to get a house. We're not going to say, oh, but you have recent convictions for drug use. You don't deserve to have access to this supplemental program. Like, oh, you can't find a landlord who's able to provide you this because your credit is bad. Well, that's a shame. Like everyone's got to have a roof. This is really key. And so they're thinking about it differently. Not everyone, we don't have to think about it exactly the same way, but like, again, it doesn't have to be this way. It doesn't have to be this sort of labyrinth of policies and restrictions on who's eligible for this kind of thing. And so what the system that you're probably familiar with, the system that we sort of exist in the United States, is what's called the housing readiness system, where it's a very long, winding process bringing you from experiencing homelessness to permanent housing. And the longer and more winding the process, the easier it is for someone to fall out of the system along the way. And so you can go from homelessness to a temporary shelter for a night or for a few nights. If you have any behavioral problems, if you have mental health issues, if you have medical issues that prevent you from sort of staying connected to that system, then you can sort of disappear and then no one will ever follow up with you. And so you just kind of wander away and then no one ever looks for you. If you're lucky, you can make your way into transitional housing. So you might be in a halfway house, you might be in a semi-permanent thing. We can provide this to you for 3 months, for 6 months. We can provide you this kind of housing. We can provide you with that. But if you don't have enough income, if you aren't able to find a landlord who's willing to accept your application, you still have to be accepted by a landlord, then you fall back out of the system, then you're either back into shelters or back into experiencing homelessness, and you have to start all over again. If you're lucky and everything goes right, then yes, you can make your way into permanent housing, but a lot has to go really, really well, and you have to have a lot of luck to get there. And so the idea is we need to have a system that requires less luck and that is actually able to move more directly. And so we need to go immediately from homelessness to permanent housing. From there, once you have an address and a phone number and a place where you can take a shower and you can get dressed and maybe get ready for an interview, things like that, then you can have access to more reliable medical care, mental health care. You can have a social worker who knows where to visit you. And you have all these sorts of things. You can have a relationship with your home and actually start having it be, rather than a place that's just a roof, then actually is a home. And you can actually have some life stability. So right now, what I find especially interesting is there's a lot of empirical research being done right now on like, so how does it work? Like, we could try it. We can actually test this out and see what happens if we provide people with immediate access to permanent housing. Like I am experiencing homelessness, like, great, here's your apartment, here are the keys. Like, okay. And so what does it do? And so people are looking at it from all these different angles. They're looking at it from the angle of, what does it do to patterns of homelessness? What does it do to patterns of health inequities? What does it do to mental health care access? Are people more likely to use a therapist if they have a permanent residence? Are they less likely to be arrested? Are they less likely to go to prison? Are they more likely to, what are the costs to a city overall if this is the case? So people are looking at it from all sorts of different angles based on what their interests are. And what it seems like, based on the data so far, that housing first, like you go directly from experiencing homelessness to here are the keys to your apartment. It's either less costly than existing homelessness policies, or it's possibly a little more costly. So basically it sort of breaks even on what the overall costs are. And interestingly, that people experiencing the thing, they would much prefer to not have to go through the long winding labyrinth of processes of trying to get from eligibility to eligibility to eligibility to luck to luck to luck and to eventually getting into housing. One interesting study found that when LA County, so one of the places sort of like a huge epicenter of experiencing homelessness, they saved $1.20 for every dollar they spent when they tried to provide housing to unhoused people who went to the ER. And so people would show up as what's sometimes pejoratively called, I kind of hesitate to use the term, but I think you should be aware of it, called frequent flyers. And so people that show up at the ER, and they show up at the ER again, and they show up at the ER again. And sometimes it's the same problem, sometimes it's a different problem. And the people who work there sort of roll their eyes. They thinking as prisoners of the proximate sometimes will say like, oh, it's this guy again. What did he do this time? Did he sprain his ankle? Is he intoxicated? What's the problem this time? And every time it's extremely expensive to go to the ER if they can't pay their bills. In the United States, the one thing you have access to that you're guaranteed is that you're allowed to get emergency care. If you can't afford it, then the hospital eats the bill and gets really pissed off about it. And they try to get grant money from federal or state agencies, things like that, to try to cover part of it. And so what they found is if you find people who are experiencing this and they're going to the ER all the time, you say, okay, here's your apartment, go live here. Then it actually saves them money. And so like the idea that maybe it's either kind of like breaks even or it saves money to give people immediate access to permanent housing, I kind of feel like the talk can end there for me. Like sort of where I'm at is like, okay, it's like it's cheaper to give everyone housing, or it's about the same as what it is now. Like, okay, done. But I know you might need a little more convincing. That's why I have like a whole talk about it. Anyway, it doesn't have to be this way. We don't have to be doing it this way. Instead of having, so we could have had rental assistance where instead of saying that you just don't have to pay your landlord for a while, but you're gonna have to pay them later, we could have had, here is your check to help you pay for your rent. But we didn't do that. We could have housing first. Instead, we have this like bizarre labyrinth of ways of trying to get through Section 8 eligibility in order to find housing. We could have universal basic income instead. Instead of doing this, we could say like everyone just gets a certain amount of money. We're actually doing some experimental research right now through the RX Kids program in the College of Human Medicine, trying to look like what happens if when there's a baby that's born, you just give the family some cash. Like, here, have some money. Like, what happens? Probably good things. There's other data that points to like, yeah, having enough money to raise a child actually ends up better for everybody. Because little known fact, children turn into adults and they also have issues. And so like, it's good investment. We can have a free, safe housing for people experiencing homelessness. And instead, we have things like in the Lansing, it just near me, it really upset me. Even though the CDC, among other places, says one thing you definitely shouldn't do is if you find people who have temporary encampments in public areas, you definitely shouldn't just tear down their housing and then just tell them to go take a hike. You should provide them with like permanent transitional or permanent at least transitional housing in the meantime. But instead, we just kind of tore people's tents down and destroyed all their stuff. And so like we shouldn't be doing this kind of thing. And it's happening all across the country. It's not just at Lansing. It's happening all the time in LA County. It's happening in a bunch of other places, and it's horrible. And it's not a solution to anything. And so the problem of homelessness isn't people building camps. The problem of homelessness is people not having homes. And so I think this is interesting just from an angle of, I'm just about finishing up now, about the interplay between evidence and ethics. This is sort of the area where I work, where we have evidence about what works, and we have intuitions and ideas about like what the ethical role should be. And so how do we think about public health? What do we owe to our fellow people who live in this country? And so if someone is having a hard time, like, do we owe them housing? Do we owe them medical care? What do we owe anybody? And so all of this stuff is all in play right now. And so if you think of housing as a human right, for instance, this is an abstract claim. And so like, okay, it's a human right, sure, whatever, or it's not. That's abstract, but also it's an empirical issue that housing is a health need. And so if you look at what happens to people when they are experiencing homelessness, then you have massively higher rates of disease and death and suffering and inability sort of to make it out of that cycle that sort of keeps you in poverty and sickness. And so we have this sort of like what we know about what's going on, and we have ideas about how we could sort of think about it ethically, and we need to reconcile those at some point. So I'm not going to belabor this, but we have to think about like, okay, do we want to adopt something like a housing first intervention as some sort of efficient solution? Maybe it will be, maybe it won't be, but I think it might be. It seems like it's worth trying again and again as we're sort of doing more and more experiments with it. Something that I think it seems like at the very least, we should try more experiments to sort of see like, is this something we can scale up? Is this a thing we can do? LA County tried it. There are a bunch of other places. They've tried it in various parts of Canada. They've tried it in parts of Europe. It seems like this is a thing that could really go somewhere. Would it actually save us as a society, both money, but also like human suffering to not have this happen? So I'd like us to think about having a culture of health where everyone gets to have access to health and not just for the privileged few. I want us to all work together. I want to have people thinking about housing and urban design and environments and the way we build our cities or rebuild them. And one thing I think is important to not forget is that it's not just a house. There's a difference between a house and a home. And so it's very easy to underestimate the value of a home. And so I have this quote from Nell Noddings, who says, "The importance of homes cannot be overlooked, for they are fundamental to one's identity. Home is not merely a place in which basic physical needs are met. A real home is an extension of ourselves." And so let's not forget the sort of the very intangible but very real aspect of the difference between having a home and not having a home at all. And so there's that part too. I have these. If I can send these to you if you want, but like it's very small. Maybe you can sort of see it better. But yeah, references. Anyways, thank you. And we can continue the question from before.
We've got about 10 minutes.
Okay,
We're
no,
gonna go
good,
back
okay.
and forth between questions that we have online and then also in person. So questions for Dr. Valles.
Hi, my name is Annika. I'm a medical student. Thank you for giving this talk. I'm curious about if you can speak to what the literature says or even anecdotally about the reaction that homeless shelters or like 501(c)(3)s have, basically because they've made a business out of folks experiencing homelessness, to the housing first model and the mission to eliminate the need essentially for a homeless shelter.
Yeah, I mean, certainly there might be there are people who work inside this existing system and they are resistant to change because humans tend to be resistant to change. There aren't a ton of people making a lot of money on transitional housing. It is possible to make some, there is room for profit and for people to have jobs there. I'm not too worried about people who are sort of working inside homelessness support, sort of fighting back on this too hard. I hope I'm not wrong about that, because it is sort of a massive shift. But I think that the people I know who work in that space just want people to have homes. And so if it meant that their particular agency was sort of that basically plugs a particular gap, that if that gap didn't exist, they wouldn't be super furious. Just like I have confidence that most oncologists wouldn't be super furious if we just like cured cancer. And it's like, we cure cancer, and someone's like, damn it, what am I gonna do for my job? It's like we'll find something for you to do. Don't worry about it too much. Like, don't freak out. Like, we'll find another thing. And so like that's me being optimistic. Like, just like the oncologist won't be too mad about us curing cancer.
Other questions from the audience here?
Thank you for that talk. That was fantastic. I, as a practicing clinician, often have difficulties with seeing the forest for the trees. When I have a patient come to me, we've identified a social determinant of health of housing insecurity, and feeling powerless as a clinician to impact this.
Yeah.
Where do you see this going from a healthcare standpoint in the clinic, and how can physicians or future physicians impact upstream problems, as you were mentioning earlier? Yeah,
I think an area where I've seen a bit more action on it would be in, not to bring up yet another controversial thing, but this is the space I work in. Like, everything's controversial. Sorry, not sorry. In gun control. So a while back, there was a tweet by the National Rifle Association that was tweeting about I believe it was a group of pediatrics societies. I can't remember if it was a workshop or it might have been the American Academy of Pediatrics. I can't remember which one. Basically saying something about like, guns are a major cause of harm among children. Accidental shootings are way too common. I believe now firearms deaths have exceeded other causes of death for young children. That's true. Yes, pretty sure that just changed. And that is horrifying. And so they say, like, this is a problem. NRA says, stop trying to get into gun regulation. You're way outside your lane. Stay in your lane, was their exact phrase. And so what pediatricians and other physicians tweeted back was pictures of their bloody scrubs, saying like, oh, really? It seems like gunshot wounds are our lane. And so they said, like, no, we're not going to accept that we should not be having a conversation around the health impacts of firearms. And that one actually kind of stuck. We still continue to talk about the dangers to children of firearms if they're unsecured. And so at the very, very least, we need to have mandatory gun locks. We need to have some sort of background check system. There are lots of different sort of relatively common sense things that are even relatively politically popular, if you sort of do polling, that people would support. And that conversation, doctors did have a role in. They're like, no, we're not going to say we're not going to be part of this conversation. This is not a criticism of the doctors. It just sort of like, it's like, when they got involved in that area, people listened. If doctors started saying more about people experiencing homelessness and showing up at the clinic all the time, and what the toll of that is, and how frustrating it is, and how this seems so preventable, like maybe we could actually make some sort of impact on that. So I would love to hear doctors saying like, this is a problem. I'm not going to dismiss this as the most obnoxious person in the ER who's always showing up. What if we talk about this instead as like, this is a social problem that we should be dealing with? Because right now in the ER, I've always heard about it coded as like, again, as opposed to like, no, again, we need to fix the system. It's always like, and so like, it depends how doctors sort of receive it. And so the frustrations are there, I'm sure, but like, we could change the conversation around that. I think doctors actually could play a role.
Okay, thank you.
Hi, I'm Emily. Thanks for being here today. So I was wondering, how would you prevent someone from being or becoming too overly dependent on this form of assistance? You know, for example, and of course, these aren't humans, just a big wide example. We don't feed wild animals because they are going to become way too dependent on us and they're not going to be able to survive on their own. What would you suggest we put in place in the system in order to prevent that?
Yeah, it's this is a long-standing sort of political argument about sort of what happens both empirically and sort of like in showing up in data about like if there is too much access to unemployment insurance is an idea, then what happens to employment? Generally, what seems to happen is that it's not as bad as people sort of predict, that if there is universal basic income, if there is pandemic unemployment insurance benefits, that it becomes harder for workplaces to actually get workers to work there. But then what it does is sort of changes the conversation around like, well, maybe the problem isn't that workers are being too lazy and they don't want to work because like they would rather stay at home. Like, what if the jobs just kind of suck? And so maybe we should make the jobs less terrible or make them pay better, as opposed to think about this as a problem of like, what if people had too much support? And so we could try to think about this. So basically, we should worry about like what would sort of happen if we sort of just gave everyone free housing. Would that be wasteful? Would that sort of disincentivize people from paying their own mortgage and say, oh, I don't want to pay rent. I'm just going to say I am experiencing homelessness. I want to get free housing instead. Like that is a possibility that some people would just want to have the free thing. That's generally not the way it's happened when we have safety nets. The rest of the world has more safety nets generally than the US does. And so like, for instance, the US doesn't provide any guaranteed paid maternity leave. Basically every other country, except for 2 or 3, provides something in terms of that. And so the people always worry, like, well, if we provide this for free, people are going to become dependent on it. And so like, you should do your own savings, or one proposal is to allow people to borrow from their retirement in order to pay for maternity leave. And so like, yeah, I'm seeing some shaking heads about that. That also makes me shake my head. And so it just doesn't seem to be the way it goes. Like other places that provide more to people, and they still have people employed, and they still have people paying rent and paying mortgages and things like that. And so I just don't foresee the downfall of society. Like Finland is still doing okay. They're still existing, and they do this. And so what we can do is have the humility to sort of look around at like who has succeeded or failed around us, and try to take lessons from them. And so we are not Finland, but we can learn something from Finland in terms of, and in Canada, we can learn from Canada, we can learn from Ireland. There are lots of other places that are trying things, and we can try to see like, okay, like what works and what doesn't work. And it doesn't seem like people just get super lazy and like, oh, I'm never going to work again. I'm never going to pay my own rent or something like that. It just doesn't seem to work that way. But if it does, then we can do something different.
I want to remind the folks online that you can also put a question in the chat. We'd be happy to take it.
Thank you. I'm Kathy Maycumber. I'm the director of the BSW program, the Bachelor in Social Work program here at SVSU.
Oh, cool.
And I just wanted to make a, I just wanted to make a comment regarding your question about how, as a physician, you are going to address those kinds of issues in your practice. And I'm going to say hire a social worker.
Yep.
So the trend is perfect. Yeah, the trend is for social workers to be embedded in those clinics so that they can deal with those kinds of issues, whether it's, gun control issues and asking those questions about whether or not the guns are safely locked up, or asking the questions about and making referrals specifically for housing and to become more housing secure. So that's That's my answer.
Yeah.
Thank you.
Endorsed.
I'm glad that Dr. Maycomber spoke up, and also that we not only have social work students that are here in the audience, we have undergraduate students want to go to medical school, different health professions. The frequent flyer happens. I hear about it in my office. What does an undergraduate student do to help change that culture? Are they in a position that they can help change that culture when they hear that from these folks that are further along in their journey that they respect?
First step, and this is the hardest one, first steps generally are humanizing. It is very, very easy to dehumanize certain kinds of patients or certain kinds of people we walk by on the street. Like, oh, that's disgusting. I'm going to think about this person is not worthy of life, not worthy of my attention or care. People walk into the ER like, oh, you are a pain in my ass. You are not a person I care about. I'm using sort of the way people have talked about this. And so that is the way a lot of the conversation goes. I'm not saying that that's what particular people here did, but like I know I've heard people say it and they describe it that way. And so trying to move from like, oh, that's a person who's suffering. Why is it like that? Why do they keep showing up all the time? Like, oh, it's because they have a substance use disorder. It's like, okay, how are we doing with substance use disorders as a society? Are we doing a good job with that? Like, no. Like, okay, then like, well, maybe like ease off a little bit, huh? Like that's a human being. But that's a hard conversation to have if you're like a scribe or a volunteer or a low level anything or whatever. And so I get to get away with saying that kind of stuff if like a doctor says it to me. But I know it's harder, but like humanizing people, because dehumanizing people who are experiencing homelessness happens all the time. And so if we don't treat people who are experiencing homelessness as fellow human beings, we're going to get nowhere.
Thank you for that. We've got another question here.
Hi, my name's Haley. I'm an undergrad student here at SBSU. I actually work with one of the larger hospitals in the area, and I give a rough estimate that about 1 in 10 of the patients I do see are experiencing homelessness.
Wow.
And I know that we're actually not considered one of the bigger areas for homelessness at a country level.
Mhm.
But if there was a homeless first model that was implemented, like how long would that take to actually affect, a smaller area that does experience a high rate of it? Because I know when we do talk about it, we talk about it in states like California, Florida, Louisiana.
It really depends a lot on what the local infrastructure is, which infrastructure is not a strong point in Michigan, honestly. And so if you can get people, if there is, for instance, unused housing, that helps a lot. If there isn't, then it's tougher. Then you got to build it. And then it automatically takes years. And so you have to either do public-private partnerships where it's like a privately owned place, but the public helps pay for it, or you have an entirely public housing, whatever the thing is. If there isn't housing, you got to make it. If there is housing and it's just going unused because it's too expensive for people, then you have a shot at trying to give people vouchers so that like they can pay the landlord what they're actually owed, and then like a fair market rate or whatever, and then they can have housing relatively quickly. And then you can start seeing some impacts relatively quickly, because if someone is experiencing some sort of problem because they are experiencing this problem of exposure to the elements or being forced to be around people who are physically harming them, it could be anything. Then it can be fast or it can be slower. It just kind of depends on what the local problems are. And so homelessness is many different things. In some places, it's almost exclusively couch surfing. In some places, it is being entirely unsheltered. In some places, there's a large infrastructure of local shelters. Some places they have almost none. Some places the local shelters will allow families and some of them won't. Some places the local shelters will allow pets and some won't. And that can be like a deal breaker if your pet is your only friend, for instance. This is a thing that does happen as well. And so it just kind of depends on what's going on. So I don't know enough about the local area, but so it could be fast, it could be slower. It just kind of depends on what's going on. It's a series of lots of problems that sort of exist across the country and across the world. And I hope yours is more tractable than like the Los Angeles one is.
Any last questions from our audience? We're doing good online. Okay, fabulous. Okay.
In that case, thanks everybody. I really appreciate
Thank you
being
so
here.
much for coming out. We truly appreciate that. I'm going to give one quick plug. My students, I know you've heard about it. Michigan State's med students, I know you've heard about it. There is a movie opportunity coming up on November 14. It's called Medicine Man, the Stan Brock story. And it is an opportunity for us to find out about some of the remote ruralist parts of the United States and what healthcare looks like in those communities, or perhaps what healthcare doesn't look like because it is not happening. That's a movie opportunity. Thankfully, Michigan State's College of Human Medicine, My Michigan in Midland, and Saginaw Valley have partnered together and have made tickets available. We've rented out a theater here in Saginaw. If you are hearing this and you have no idea what I'm talking about, this is not just for Saginaw Valley students. It's for anybody in the community. Connect with me because I'd be more than happy to put you in touch with how to get those tickets. Same thing for folks that are online. You can shoot an email to me, hblang@svsu.edu, and I'm happy to make that connection. And then last but not least, we thank you greatly for coming out. Thank you for the questions. Thank you for the conversation that happened, and safe travels as you head home. Thanks.